Welcome. A case series, The Impact of a Virtual Reality Intervention Adjunct along with Conventional Physical Therapy on Functional Outcomes in Individuals with Chronic Low Back Pain. Researchers Sarah-Ann Burcham, Matthew Gallegos, Seth Mead, and Don Wynn, along with committee chairperson Dr. Jody Eckert, would like to welcome you all here today. Low back pain is the second leading cause of disability in the world. Chronic low back pain greatly impacts individuals economically, socially, physiologically, and can decrease their quality of life. Physical therapy has been established as a reliable intervention for treating chronic low back pain, according to analysis of over 60 randomized controlled trials. Virtual reality, along with conventional physical therapy, has been proven to reduce visual long scale and McGill Pain Index scores compared to conventional physical therapy alone. The opioid epidemic has reached devastating numbers, and it cannot rely on pharmacological approach alone. Studies have proven that physical therapy is an effective intervention to decrease pain and improve quality of life in patients with chronic low back pain. Studies have shown that patients with acute pain recover faster than patients with chronic low back pain, and only a third of them will recover after a 12-month period. Virtual reality can also play an important role in decreasing individuals' pain by means of creative distraction, by modulating the perception of pain perceived by the brain. The purpose of our study is to determine the impact of virtual reality on decreasing disability and pain in individuals with chronic low back pain in an outpatient clinical setting. The hypothesis: with combined treatment of virtual reality and current physical therapy intervention, there will be a decrease in pain and disability using the Oss-Westry Disability Index, Numerical Pain Rating Scale, Patient-Specific Functional Scale, Fear Avoidance Belief Questionnaire, and focus on therapeutic outcomes. Forming this hypothesis is the notion that chronic low back pain has a mental component associated with repeated exposure and pain fixation or catastrophization.
So how do we implement the research? Well, we utilized 6 outcome measures, including photo, PSFS, FAB-Q, ODI, and then within each session of physical therapy, we looked at the functional reach test and numerical pain rating scale to demonstrate an immediate improvement in functional mobility as well as a decrease in pain. Implementation of VR was added at the end of each treatment after conventional therapy, which I will describe in a later slide. Here is a table of the demographics for both of our participants. As you can tell, each were female over the age of 55, and we also included in the inclusion criteria that they had back pain longer than 3 months, rendering it chronic, as well as no prior history of back surgery and no current eye conditions that would interfere with the effects of VR. During a session, each participant completed 3 to 4 units of conventional physical therapy, which included intervention techniques such as manual therapy, pain neuroscience education, core activation and stabilization exercises, all deemed appropriate by the clinician researcher. Then, the virtual reality was implemented for 15 minutes, being 1 unit, utilizing a boxing game emphasized on functional squatting, lunging, twisting, and other movements.
This is a short video of one of the researchers playing the game.
And here's a chart that demonstrates how we implemented each of the 6 outcome measures. So as you can tell, we implemented each one of the 6 for both the initial and discharge, with the functional reach test and numerical pain rating scale being performed each session, before the session, after conventional therapy, and after VR implementation.
So since we did a case series for our research design, we used descriptive analysis to show the change from initial evaluation over time until discharge. We used means and standard deviations for continuous variables to show that change, as well as frequencies for categorical variables. We also looked at measurements within each treatment session. After analysis, we found a major change within the first 5 visits, so pain was completely resolved 100% by the 5th visit and continued till discharge. Functional reach test improved 4.13 inches, or about 37.5% by the 5th visit, and the PSFS had a 40% improvement by the 5th visit and continued till discharge. We then analyzed mean and standard deviation within the treatment session to show change between conventional PT, VR, and then a combination. We found that conventional PT alone and in combination with VR decreased pain, but VR alone relatively stayed pretty steady with their pain. We then looked at the functional reach test and found that their functional reach test increased more with conventional PT, and we actually saw a noticeable decrease following the VR training, which was likely due to the patient not being used to VR and just not being aware of the setting. The graph on the left shows the change in functional reach within each treatment session. The striped line bars are functional reach before PT, the dark gray bars are following PT, and then that black line is following VR. As you can see, that dark black line was below pre-conventional PT and post-PT, but then started to level off once the patient started getting more comfortable, and then actually started to go above. Overall, you can see the positive trend of increasing functional reach throughout the whole treatment period. On the right side, you can see that photo had a positive improvement throughout the whole treatment period as well. The next two graphs show the change in patient-specific functional scale for each of the three movements that both patients identified. As you can see, there's a major increase in function after the first 5 visits that then start to plateau off and remain steady until discharge. These next two graphs illustrate the change from initial till discharge for our FABQ and then our ODI. As you can see, we failed to obtain quite a few measures for patient A, but we did obtain all of the measures for patient B, and you can start to see a noticeable trend of decreasing in FABQ and ODI throughout the whole treatment session.
The positive effects of using virtual reality along with conventional physical therapy, as well as the enjoyable patient experience, gives physical therapists another tool to improve outcomes. Further research should increase clinical participants to improve the validity of the results and obtain a larger data set to compare results. We advise to record Oswestry Disability Index on initial and discharge, since that will reflect significant change, and decrease outcome measure recordings will decrease clinician error. Additional considerations include recruiting more than one research clinician, eliminate previous back surgery within 1 year from the exclusion criteria, use independent variable or randomized control trials, or change the order of conventional physical therapy and virtual reality. In conclusion, VR in conjunction with conventional physical therapy display positive effects on pain, function, and mobility in patients with chronic low back pain. With that being said, our results tend to favor conventional physical therapy over the use of VR to treat patient pain and mobility, maybe due to the fact that it was a small sample size. Patient functional status and fear avoidance behaviors were improved. Further research is warranted to increase patient population and validate results across a broader population. These are our references. Special thanks to Dr. Michael Parker for his continued guidance and to the NDPTA for their monetary assistance via their research grant.